right, very good. Thank you everyone for joining this afternoon. I'm Jennifer Geremia. I'm a physician assistant in gastroenterology currently at the Brigham in Boston. And I previously was practicing in the community setting in Rhode Island for over a decade in gastroenterology. So thanks again for being here today as part of the MASLD Community Network that's sponsored by GHAPP and Madrigal. So our task for today is really sort of differentiating the F3, F4 fibrotic versus cirrhotic patient and how we differentiate those people and the nuances in terms of managing them. For anyone here, if you want to go ahead and scan the code to register and record for today's meeting, I'll leave that up there for a few seconds so you can take some time to do that. Okay, so let's kind of jump into it here. So this is a hypothetical patient, but I think it's a reasonable representation of our bread and butter patients that we see across all disciplines, not just in GI or hepatology. So whether that be internal medicine, primary care, endocrinology, surgery for bariatric procedures, etc. So I think this is a good representation. So we have our patient here who's a 55-year-old male, Caucasian. He is by BMI considered obese, BMI of 33. And he was referred, which is one of the most common referrals to gastroenterology, for the evaluation of abnormal transaminases. And in this case, the primary care or the referring provider had the fortitude to start with an ultrasound. Sometimes we get them with no workup. And what basically the ultrasound showed was an increase in echogenicity that, is likely consistent with fatty liver is what we would imply from that verbiage. And he also, in terms of review of symptoms, was globally complaining of fatigue, which certainly is not particularly specific, but something that he expressed concern about. On intake, he has, fairly classic metabolic syndrome here, apart from his BMI. So type 2 diabetic, he's hypertensive, hyperlipidemia, sleep apnea. Upon review, he denies any alcohol use. One sort of call out here in terms of my personal practice and working up liver patients, because we know sort of alcohol can sometimes be a sensitive subject, especially if the patient doesn't have a rapport with you yet. So, if they pretty much know, I don't drink or what have you, if they do, and it's like daily use, or you sense that they potentially could be underreporting, I do now utilize PEth testing as part of my liver workup, just like I would rule out autoimmune or infectious etiologies of liver disease. So if there's a concern there for true blue sort of reporting of alcohol use, go ahead and do a PEth test. I sort of liken it to the hemoglobin A1C of alcohol. It kind of gives you a nice lens into more chronic use. On physical exam, he has an obese abdomen. So we know in the realm of metabolic syndrome, right, large waist circumference suggestive of visceral hypersensitivity as a risk factor for a fatty liver. And that was appreciated on exam. No particular stigmata of advanced liver disease, right? So no appreciable ascites, peripheral edema, and anasarca. And no hepatomegaly, although I think that we do have to take a moment of pause and think that he does have a large abdomen with adiposity and he's obese, so sometimes that may not be palpable with his body habitus. He's on several medications to address his chronic condition, so fairly standard ACE inhibitor, statin. He's also on ezetimibe for the lipids, and then an SGLT2 here for the diabetes. So looking at his overall workup here, so slightly hypertensive on exam. We already know he's obese. I mean, his transaminases are high, but certainly not glaringly concerning that we're thinking of an acute, like drug-induced liver injury or an acute infection, but nevertheless abnormal. I think one thing here, if we're thinking about, okay, the integrity of this patient's liver, we always think about synthetic functions and what are their coags. So his platelets are sound, his INR is sound, so that lends itself against any type of risk factor for cirrhosis or portal hypertension. Diabetes certainly is not up to snuff here with an A1C of 7.1. Looking at the totality of his workup, so his ferritin is high, and that certainly doesn't call it does not make the call that he has hemochromatosis, right? Because we know ferritin can be high in metabolic syndrome. We know ferritin can be high as an acute phase reactant from other disease states. We know it can be high with alcohol, but nevertheless is part of our workup. So we always have to marry that with the iron saturation, which here is at 30%, so a little bit borderline. His ANA was positive. Again, ratio is not staggering, but when we think about sort of autoimmune hepatitis, that would certainly be on our differential list here. Leans against it because the ASMA was negative, and then infectious pathogens like Hep C and B would otherwise are negative here. So we're not concerned for an infectious pathogen here, acute or chronic, in particular with C and B. So doing a quick FIB4 calculation, which is super easy. You can plug it into the majority of sort of medical calculators. We have it as a dot phrase as part of our EMR, so it's quite easy. Now, we know that there are some limitations to FIB4, but it is a very easy screening tool, especially for non-GI providers, to screen their patients as far as who potentially needs to go to GI for workup. Remembering that this is a calculation that encompasses the patient's age, AST, ALT, and platelet count. Age often tends to be a limiting factor in the sense that if you're too far outside of the range, he's not. But, being middle-aged but too young or too old can sometimes score that out incorrectly. So the ranges really tell us is that you're a low-risk individual for fatty liver fibrosis, less than 1.45, indeterminate is considered 1.45 to 325, and high risk. So we're not diagnosing him with fibrotic disease, but he is at risk based on his FIB4 score at a 3.1. He's right at that cusp of indeterminate to high risk, okay? So once we've determined that someone either falls into an intermediate risk factor or high, then we need to do some type of second line non-invasive testing here. Now, whether that be that you do it within, again, your practice, if you're a non-GI provider, or refer to GI. And this really encompasses one of two things for the most part, is going to be either liver elastography or FibroScan, which is an ultrasound-based protocol, as we know. And that gives us two scores. It gives us the stiffness score, and it also gives us the CAPP score. So what is the burden of steatosis that the patient has? Understanding that there can be, again, some limitations. So body habitus is their BMI above, close to 40, so above 35 or 30 to 38, starts to get less reliable. Did the technician have a hard time getting a lot of pictures, right? And so what is that IQR code, right? So we want a percentage of ideally less than 30, more so even less than 20 for that to be reliable. So all things being equal in terms of the quality of the FibroScan results, what are we looking at here? So typically 2 to 7 is considered to be normal. There is no fibrosis, so like a 0-1. When we look at AASLD guidelines, right, they're sort of classifying F2 as anything 8 or higher. So here, when the range is a bit wider, so 7 to 9.5 is mild to moderate fibrosis, so your 1-2s. 9.6 to 12.5 is considered an F3, and our differentiating factor here is 12.5 or higher is considered advanced fibrosis. F4, so essentially cirrhosis, decompensated or not. And then our CAPP score, again, looking at how severe the steatosis is. If you don't have access to FibroScan, or there's concern about disconcordance, maybe the quality of the exam wasn't there, then you can also do an ELF test, which is a proprietary serum test that is a send out and pretty much available in all labs now, that looks at a variety of biomarkers in the serum to, again, risk stratify. So less than 7.7, virtually no fibrosis or mild. Anything up to 9.8 is moderate, 9.8 or high, or essentially to 11.3 is severe, and cirrhosis above 11.3. So would there be any further testing that I would personally perform in the GI clinic on this patient? So a couple of things. I already sort of alluded to sort of the PEth testing, right? We weren't particularly concerned with alcohol in this patient. I think what I would say, there was that positive ANA. Yes, his anti-SMA was negative. I don't know what his AMA status is from the deck, but I think if there's a concern that there could be overlap autoimmune disease, PBC, PSC, hemochromatosis, whatever it may be, that if you are concerned, again, that there's multiple markers that are high, and this is very classic fatty liver fibrosis, but if you are concerned, then you may want to consider a biopsy. You do not have to, but he was positive for ANA with a ratio over 1:40. So just something to potentially consider here. And so there really was no disconcordance. So all other things being equal and all the other diseases being ruled out, right? As causation here is, staging. The FIB4 was, scoring at that sort of indeterminate or intermediate to high. He had 2 non-invasive tests. You do not need to do 2 unless there's disconcordance, but in this case, there's 2 that support one another, right? So there is no disconcordance here. So he is falling into that bucket of the moderate to advanced patient at an F3 by all metrics here. And so as far as approaching this patient, so he's F3, fatty liver fibrosis, no other concomitant liver disease, with comorbid risk factors for MASH with fibrosis, right? So this is a patient that you could reasonably offer Resmetirom for because it is approved for patients with F2-3 fibrosis in conjunction with lifestyle, right? So when you are treating patients with MASH, irrespective of their fibrotic status, you always have to address the comorbid conditions that got them there, right? So his A1C was not up to snuff. So do we need to potentially consider additional therapies? He's only on 1 agent for diabetic control. So whether that be yourself or you collaborate with his other practitioners to get his diabetes under better control, of course, lipid management and weight management, right? So it's all in conjunction with lifestyle. And we know from a weight metric that you need a minimum of 7 to 10% for there to be meaningful reduction in steatosis burden and fibrotic risk, and that needs to then be maintained. So things to consider. And as far as monitoring him, really, so he was defined as having F3 fibrosis, okay? And we know that in cirrhotics, when they're the F4s, whether they're compensated or not, irrespective of causation, every 6 months we're doing either ultrasound or MRI, AFP, for screening for hepatomas and potential risk factors for HCC. We know that advanced fibrosis F3 non-cirrhotics are also at risk for hepatocellular carcinoma. So once we've identified them, then they also need monitoring, because any type of remodeling of the liver can be a risk factor. So as I alluded to, Resmetirom is a completely reasonable option given his MASH fibrosis. I already alluded to lifestyle modifications, and of course GLP can address his diabetes and his weight. So that could be part of the conversation to address both metrics here. And as far as monitoring for HCC, again, you want to probably manage that with GI. I'm not necessarily implying that PCPs or non-GI providers should be responsible for that, but it is something that would need to happen in this advanced fibrotic patient. So if we take our same patient with just some subtle nuances, right? So his medical history, his intake, his review of systems, his medications, all being completely equal. But when we start delving into his workup, we see some things here that are a little bit different than the F3 patients. And someone may look at this and sort of glaze over it and not find it particularly significant, but from a hepatology lens, there are some significance here. So our platelets, right, if he was F3, was 157. And here we got 128K. So already starting to see sort of that thrombocytopenia presentation, which is one of the earliest signs of change in synthetic function related to liver disease or cirrhosis. Again, his alkaline phosphatase is exactly the same. Transaminases, nothing glaringly different here. Again, INR was normal. So really it's the platelets that's sort of the tip off here, and the rest of the workup is otherwise the same. So it really was the platelets that, again, we may look at and may not blink an eye at or be particularly worried about, but it is a differentiating factor here. So now when we look at sort of that non-invasive testing and we go through that same structure, okay, so we see here in the FIB4, he still falls into that intermediate risk. So if we go to, sorry for the flipping here, his score scores out the same. Even though the platelets, right, are part of the calculation, the platelets aren't so low that it tips the FIB4 into a higher category. So that's why FIB4 is a really nice starting point, especially for non-GI providers, but needs some follow-up when you're in that intermediate to high risk. There is now a distinct difference between his FibroScan results. So his CAP score is the same. The burden of fatty liver is the same as it was in our prior study or prior case presentation, right? So that didn't change, but his fibrosis score is now 21, where before he fell into our F3 category at 11, so about a 10-point difference. So now he really is qualifying into that advanced fibrotic stage. And again, looking at ELF testing, that also sort of supports that. One thing that is not accounted for here, and I will tell you, I work in tertiary care. I have access to things like MRI elastography. I do very little of it, but theoretically, that could also be a second line, especially if the quality of the FibroScan is poor or those metrics like a particularly high BMI, image quality, etc. It could be another potential exam here. But looking at FibroScan and ELF score, they're both scoring him in a higher risk category as being, F4 cirrhotic. And he has no stigmata of ascites or peripheral edema, anasarca, etc., so not likely to have portal hypertension. But as far as testing and follow-up on this patient, it is going to look a little bit different because he is going to need evaluation for portal hypertension. So similar to our prior case, right, as far as further testing, if there's a concern for concomitant liver disease, go ahead and potentially consider that biopsy to rule out any other causation, especially in the F3 patient. So for two reasons, right? You want to treat what the problem is that's got the patient there, and maybe they have more than one problem. But secondarily, it is important in that F3 patient, if we're going to consider Resmetirom, you don't use Resmetirom if they, for example, also have PBC or autoimmune hepatitis. So you do want to differentiate that. Our non-invasive tests are not disconcordant. They are stone cold calling him as cirrhotic and he has low platelets. That also suggests that that would be the case. So he, unfortunately, at this juncture, so those slight nuances, right, he's no longer a candidate for Resmetirom as it stands right now. So please make note that it is not for your F4s, even if they're they're not decompensated, they're well compensated, no major issues, but nevertheless, it's not indicated. So we would not treat that. So really the only course of action at this point is really aggressively working on lifestyle to get that minimum of 7 to 10% total weight loss, addressing those comorbid conditions, probably adding on the GLP with the lifestyle to get the diabetic numbers down, because we do know that diabetics in particular are at greater risk for fibrosis. Not exclusively, but that ups the ante basically in terms of that risk profile. And he would need some additional monitoring here. So we already sort of alluded to the F3 patient needing, HCC screening, so AFP, monitoring with ultrasound and MRI alternating every 6 months. But in this case, even though he doesn't have any ascites, etc., there is the need for esophageal variceal screening, right? Because the last thing that we need is for him to sort of present with a massive GI bleed and hematemesis in the ER because an EV was missed that could have otherwise been banded. So once you've identified cirrhosis of any causation, right, then we need to drop a scope, make sure that there's no esophageal varices as part of that portal hypertension workup. Historically, when we kind of, in the alcohol realm, right, our patient case B here, we would definitely discourage any type of alcohol consumption. In fatty liver in general, in MASH, I would still argue in case A, no alcohol. And again, he was denying any alcohol use. With a MASH patient without cirrhosis, there is some wiggle. For women, 20 grams, men 30 grams. So that's a common question, like, can I ever drink, right? So if you're ever faced with that. So sort of looking at at our patient side by side, again, it was very nuanced, but very distinct. Fib4 identical, that platelet count did not move the needle as far as shifting him into that sort of higher category. ELF scores were markedly different. Liver elastography was markedly different. And so that's the nuance in sort of who do we treat with something like resmetirom, who do we not, and who do we now worry about complications from cirrhosis. So I've already sort of alluded to this a little bit. How do they compare in management, right? So, you know, I always sort of tell my patients when it comes to weight management, you know, weight management is like legs of a stool, and each leg has to be equal to stay upright. So one leg is going to be potentially medication. So we talked about, you know, something like GLP and optimization of making sure his diabetes is well controlled. But that lifestyle part, what does that look like? So high protein diet, 50 to 60 grams of protein minimally to prevent sarcopenia. We know patients with a particular cirrhotic disease are at risk for sarcopenia, and get moving. And I use the word activity instead of exercise because I think it's more palatable and achievable. So activity could mean a 15-minute walk. It could mean a 10-minute YouTube stretch video, seated stretches, you know, something that is beyond sort of this impression of needing to be Iron Man and go to the gym. So what's meaningful here is about 150 minutes per week. So those are some of the things to think about as far as lifestyle and touch points with the patient. Of course, we know that our F3 patient would be a candidate for resmetirom. Our F4 would not, and F4 would require some additional screening beyond HCC screening for portal hypertension complications like varices. As far as non-invasive testing and kind of differentiating, and I alluded to this earlier, right? So I am in a facility that has multiple FibroScans. So I am, you know, blessed to have that. So I can send the patient down the hall, even if I'm at a satellite office, and our techs have very high volume. But I also came from the community setting, so I can appreciate, and we didn't have a FibroScan in our GI office in the community setting. So I get it that that's not the most accessible. So I think use what you have at hand. And I think if you do not have access to FibroScan easily through radiology departments, et cetera, go ahead and do ELF testing, because pretty much all labs can order that and send it out. Just make sure you're going ahead and coding that properly for fatty liver, or as part of the code, just because you don't want the patient to kind of get dinged for a bill there. But do I use ELF now? Sure, I still use ELF. You know, we get referrals for patients that live further away from our facilities and may not easily come in for the FibroScan. Sometimes there's disconcordance. Again, you know, I had a patient recently whose BMI was 45. That really makes the potential quality of the exam lower. Our techs will also tell us, hey, I've taken more than 10 pics here, and I'm not getting a good quality exam. So if you get a report that's got like, 30 images, that tech was having a tough time. So that really does reduce that reliability. So I may use ELF as a secondary test much more over MRE because it's easier, it's cheaper, it's more accessible. So that's how I approach it. But if you don't have good access to FibroScan, then go ahead and use ELF. And then HCC really is important for both of them, because we know that hepatocellular carcinoma can happen with chronic inflammation and scarring of the liver. And fatty liver is becoming one of the number one reasons that people are having transplants, in particular in females, as the number one causation. And, with hepatocellular carcinoma, that's pretty much a death sentence when we've identified that. And a lot of patients with HCC were never staged as having had fulminant cirrhosis. So again, it's very nuanced, but that risk carries for both of them. So we have a few minutes here left, so I'm happy to take any questions that you may have. And this is a separate QR code if you want to visit the GHAPP MASLD Community Network to see a variety of educational programs, resources, and more information regarding resmetirom. And thank you for coming in today.